Alrighty, so I just want to break down subclavian. Alrighty, so I just want to break down subclavian steal syndrome a little bit more, just because we kind of went over that kind of quickly. Just want to make sure you all have a good understanding of this, because most likely this is going to appear on your registry, and it's important to understand it in terms of the hemodynamics and the principles, because it'll help you to also understand more collateral circulation when we get into the circle of Willis and body's responses to occlusion and blockage. So I drew our picture of our aortic arch. So we have our aortic arch, our branches, brachiocephalic or innominate artery, left common carotid artery, and left subclavian artery for our branches. Vertebral arteries, we know, are both branches off of the subclavian arteries. We have right vertebral, left vertebral. So the reason we develop steal syndromes are due to blockages or occlusions in the right brachiocephalic or innominate or proximal right subclavian arteries, or a blockage in, say, the proximal left subclavian artery. So I actually kind of misspoken a little bit before regarding flow direction, but this will help to clarify it a little bit better. So if we're on the left side and we visualize retrograde flow in the left vertebral, so flow going down as opposed to up to the brain, it's going to be due to an occlusion or a high-grade stenosis or blockage within the proximal left subclavian. So left steal due to occlusion / stenosis proximal left subclavian artery. So when we see that retrograde flow and we demonstrate that it truly is retrograde, we then have to add on some additional images onto our protocol, and we try and image that proximal subclavian artery and try and find that blockage or stenosis. Now, depending on anatomy, we may or may not see it, but we can potentially see elevated velocities, or we could see post-stenotic waveforms. So if we're able to find that stenotic lesion, great. You know, we could prove it to the radiologist, like, hey, you know, they got this high-grade stenosis or it's occluded. You know, this is the cause of that subclavian steal syndrome. And then, you know, the doctors and surgeons can plan accordingly. If we're not able to visualize that blockage or stenosis, they may go for additional testing. They could potentially do, you know, a CAT scan angiogram, a CTA, or an MRA. So if we then go to the right side, we could have two potential sources of stenotic lesions. So if we have retrograde flow in the right vertebral going down, but we have antegrade flow in the right common carotid artery, we can then tell that the stenotic lesion is going to be in that proximal subclavian. But if we're Dopplering and we see retrograde flow in both the right common carotid and the right vertebral artery, then that stenotic lesion is going to be more proximal. It's going to be in that right innominate artery. So retrograde flow in both right vertebral and right CCA, retro flow in both vert and right vert, and right CCA. Occlusion in innominate artery. So retrograde flow in both vertebral and CCA. Occlusion is going to be more central, more proximal to both of those vessels. So it's going to be in the right innominate artery. Retrograde flow only seen in the right vertebral. Occlusion is going to be in that proximal subclavian vein. Right vert. Retro flow. Flow only. Occlusion. Right subclavian. So with any Steele syndrome, it's due to occlusion proximal. So remember that it's a proximal occlusion that's creating this Steele syndrome. So regardless of where the occlusion is here on the right side, we'll still have lower brachial pressures because we're taking our pressures down in the arm. So the side of the occlusion will have the lower pressures. So in terms of flow, regardless side occlusion. Actually, no, I don't want, let's reword that. I don't like that. So in terms of flow, contralateral vertebral will demonstrate increased flow. So what that means is if I have a Steele on the left side, the right side is going to demonstrate increased forward flow to compensate. If I have a Steele on the right side, then the left side is going to demonstrate increased flow in that vertebral to compensate. Again, if the occlusion or the Steele is on the left side now, it's not affecting that left common carotid artery. So we can have increased flow in that left common carotid artery. On the right side, it's a little bit different. That's where I kind of misspoke before. So if we have a blockage in the subclavian and we have retrograde flow in the right vertebral. We could still now potentially have increased flow in that right common carotid. But if that lesion is more proximal before the right common carotid artery, then we have retrograde flow in both. And if we have retrograde flow in both, then we'll see an increase in both common carotid and an increase in the left vertebral to compensate for those two being retrograde. I hope you can kind of appreciate and understand that. Okay, so da, 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 da. So therapeutic interventions. Prophylaxis. Preventative. So under that, we'll have stop smoking. Station. Change diet. Lower fat intake. Cholesterol diet. Exercise. We have medical treatments. Yeah. Anti-platelet drugs. Antiplatelet drugs. That includes aspirin, Plavix, Tislin, inflammatory, drugs. Over here we also have aspirin. We have vasodilators. This is Persantine. Trentol. Trental. Trentol. And we have also antithrombotic and anticoagulant medications. Over here. There. That's so that would include heparin, warfarin, Coumadin, Orpanox. So those would be our anticoagulation medications. Coag. And then our TPA would be our thrombolytic. little T, big P, big A, TPA. Thrombolytic. So that one actually breaks up the clots. So remember the difference between thrombolysis and anticoagulation. So TPA would be a thrombolytic where it breaks up the clots. TPA. So then we have surgical interventions. So our first one is going to be an endarterectomy. So this one we actually get involved with in the ultrasound world because these surgeons, the vascular surgeons, will actually call upon us to come up to the OR to scan these. So this is a surgical procedure to surgically remove the atherosclerotic material and plaque, and usually a portion of the intimal lining from the arterial lumen. So this is surgical removal of atherosclerotic plaque. And usually portion layer. Surgical removal of atherosclerotic plaque and usually a portion of intimal layer from the arterial lumen. So with this procedure, they're actually, that's so awkward. So they're actually going in and cutting open the carotid artery, opening up the vessel, and surgically removing the plaque from that vessel to open it up and free it up. So these patients, the blood flow is actually shunted around the area that they're working, and so it's able to still get to the brain. So these patients, aren't going long periods, without blood flow going to the brain. But so this carotid endarterectomy is performed in patients that have high-grade stenoses. So we don't do this in patients that just have a little bit of plaque. There has to be significant plaque for the surgeons to perform this procedure. So it's with asymptomatic patients. Asymptomatic patients. They'll typically have a stenosis greater than 80%. Or when contralateral occlusion is present, or when contralateral ICA occlusion is present. So the patient's asymptomatic. They usually won't do a surgical intervention until there's at least an 80% or greater stenosis in the ICA. So stenosis of greater than 80%. ICA. When we're talking about stenosis, these percentages, it's all ICA. That's what we really care about. So asymptomatic patients, it's a greater than 80% stenosis in the ICA if they're asymptomatic, or they won't wait till it gets to 80% if the patient has a contralateral ICA occlusion. So if the other side is blocked up, they're not going to wait that long. It poses too much of a risk, too much of a danger. And you have to remember that that one ICA now is compensating for the whole brain. So they have to make sure that ICA stays open to prevent the patient from developing ischemic injuries in the brain. So if the patient is then symptomatic, the threshold drops a little bit, and it's a greater than 70% stenosis in the ICA. So with symptomatic patients, you have a ICA stenosis greater than 70%. It's still significant, still a high-grade stenosis, but the percentage just drops a little bit based on whether or not the patient is symptomatic or not. And we also have to take into account too the patient's medical history if they've had previous TIA or CBAs. So also consider history. That's abbreviation for history, HX. TIA or CBA. So the purpose of the endarterectomy again is to open up the vessel, remove the plaque, open it up. Sometimes they take a portion of the intima as well. And when they're closing it up, sometimes if the vessel is very small, they may actually put in a little bit of a patch to kind of make that vessel a little bit wider in diameter. And that patch can be visualized on ultrasound as well. So if we're imaging, so if we have our ICA up here post-surgery, they've not cleaned up the plaque, the vessel's nice and wide. Sometimes you could see the area of the patch, you'll see like little echogenic dots. Intimal layer. Patches. So you can kind of tell that it looks a little synthetic. There's some good pictures of this in the PowerPoint that you can refer back to. So if you scan this patient post-endarterectomy, you'll see the scar on the neck. I mean, they'll know their history. You'll have it when you're going in. You'll realize, that they've had an endarterectomy. We follow up these patients, on typically a yearly basis, just to ensure, that there isn't reformation of plaque, that the vessel's still open. The other thing is for the potential of something called intimal hyperplasia to develop. So this is something that could develop post endarterectomy, and we're going to go into that in just a minute. But you could potentially see also, I just want to show you could potentially see something called a patch in the area where they did the endarterectomy. So they're going to clean up that bulb and proximal ICA area. So like we said, this is usually our area where we're going to develop most of our plaque. So they're going to open up the vessel, now proximal ICA and bifurcation. And the bulb, they'll open it up, remove the plaque, try and open up the vessel. Then they take a portion of the intima to open it up more, make it nice and wide. Well, now they have a nice, clean carotid artery. So that's your endarterectomy, the surgical removal of the plaque. So like I said, there's a condition that's called intimal hyperplasia. Intimal hyperplasia. So this is a thickening of the tunica intima of a blood vessel as a complication of a reconstruction procedure or endarterectomy. So, thickening. So that inner layer, the tunica intima of a blood vessel. As a complication of a reconstruction procedure or endarterectomy. So intimal hyperplasia, it's a universal response of the vessel to injury. So this inflammatory process, this hyperplasia, this thickening of the intimal layer, it's a normal physiologic response to vessel injury. So it becomes inflamed and thickened. So it's normal. Universal response, normal and response to vessel injury. So the body doesn't, differentiate between a vessel injury, that happened versus us getting surgery. Surgery to the body, it's an injury. We're damaging that vessel. We're cutting that vessel. So it is a important reason of late bypass graft failure, particularly in vein and synthetic vascular grafts. So universal response to vessel injury. And main reason failure of bypass graft so particularly synthetic and vein grafts. So we wind up with this hyperplasia, this thickening of the vessel by the connections, those anastomoses. And when we get those blockaging or narrowing of those anastomoses, those connections, we wind up with the graft failure. So with intimal hyperplasia, occurs 6 months to 2 years post-op / procedure. So this isn't going to occur immediately after the patient has their endarterectomy. It's going to take a little time for it to slowly develop. So usually the time window is between 6 months and 2 years. So if we're imaging, we have our vessel again. So what it's referring to is the thickening of that intimal layer. as an inflammatory response to the surgery. So we get this to varying degrees, you know, post-operative, but it's when it becomes severe and becomes an issue that it now starts to limit the blood flow getting through. So we've now created a stenosis again, where we've gone in and removed the plaque and opened up the vessel. As a result, post-op of this intimal hyperplasia, this neo-intimal hyperplasia, that might be another term that you might see, neo-intimal hyperplasia, a new intimal hyperplasia. We now have thickening of that vessel, which creates a stenosis and narrowing of the vessel, which occurs typically between 6 months to 2 years post-op, post-endarterectomy, post-procedure. So on the registry, you might be asked, you know, to differentiate, you know, between, they may give you a scenario where, you know the patient had a history of an endarterectomy. They'll probably give you the time frame as to when they've had it. And then they'll say the sonographer notices, you know, like increased velocities in the area where the endarterectomy was. Could it be, you know, reformation of plaque? Yes, that is a possibility. For reformation of plaque significant enough, you know, to create a high-grade stenosis again within 2 years is very unlikely. So that's a process that's going to take more time. So that's how you really differentiate between intimal hyperplasia and the reformation of plaque, is that time frame. So another option, if the surgeon doesn't decide to do an endarterectomy, would be a carotid stent. So with the carotid stent, there are some complications that are associated with stenting of an artery. So complications. Procedure. Include dissection, and potential for embolization. You're going into this vessel now to try and insert a stent. You run the risk now of potentially dislodging some plaque and creating an embolism. As well as you also run the potential of creating a dissection as well. So evaluation of patients for carotid stenting will include, so we determine plaque morphology. So what type of plaque is it? Is it calcified? Is it soft plaque? Heterogeneous, so plaque morphology. Vessel anatomy. So what that means are the vessels very tortuous. It's going to be hard to stent open. Is the area that we're stenting, is it on a curve or is the vessel straight at that point? Because if you're trying to stent open a vessel that's very tortuous or very curved, that can be quite difficult, and the stents may not be a good option. The vessel anatomy, assessing for tortuosity. So stents are pretty obvious when we see them, because they're man-made. They have a very unique appearance. It almost looks like you'll see the studdings of the walls of the stent. It look like a railroad track appearance. Here we go. We'll share screen here. Let's open this up. There you could see, along the periphery of the stent, you get those studdings. And then here you can see almost like the mesh appearance of the stent. Depending on how you angle, you could appreciate a little bit better. So you can see where the stent begins. So this would be some plaque along the intimal layer. Stent begins in this area. Again, another image you can see here. Appreciate that echogenic intimal layer here with your studding. So those are the marks at the beginning of the stent. See again here, that's where the stent begins. You can appreciate that mesh appearance here for this particular stent. So again, this goes in, they go in, insert the catheter, run it up through the artery. What they do now is they usually try and go through the radial artery. That's like the newer approach. Sometimes they go through the artery in the groin, femoral artery in the groin, and snake their way up. But now they've been trying to do a more proximal approach. But anyway, they snake their way into the carotid artery and then open up their stent and try and open up that channel for the blood vessel. So this is a good picture showing, like before stent and after stent. Again, you can imagine, if this is plaque, as you go in and balloon open the stent, you do run the risk of potentially dislodging some of this plaque and creating an embolic event. All right, so the last surgical procedure could be a carotid bypass graft. Now these aren't that very common. These are, quite uncommon. I've only ever encountered maybe a handful of these. So for carotid artery bypass grafts, this is a bypass or reconstructive procedure. that are used where endarterectomy may be inappropriate, such as in severe stenosis or carotid or vertebral so a severe stenosis that's at the origin of the carotid or vertebral arteries. If the patient has a carotid aneurysm in conjunction, or recurrent stenosises with multiple repairs. So, carotid bypass graft. We'll put here. So, an option when stenting or endarterectomy cannot be done. So examples of that would be stenosis, origin of cerebrals or CCAs. Aneurysm. Or if the patients had recurrent stenosises with multiple repairs. Recurrent stenosis. Multiple repairs. Well, that's the patient, that keeps developing plaque, even though we've done the endarterectomies, we've tried stenting it, we've done other options. So grafts may be synthetic or autogenous of venous origin. Grafts synthetic or autogenous venous origin. So the common grafts are going to be a corado-subclavian graft. Corado-subclavian. We also have a carotid graft. Carotid. And we also have an interposition graft. So with our corado-subclavian graft, it connects the subclavian artery to the ipsilateral, the same side proximal CCA. Subclavian. Next. Subclavian. Artery. Ipsilateral. Prox. CCA. So what does that look like? An arch. So we'll have a graft that connects the proximal CCA to the proximal subclavian over here. So this would be in the case of a severe stenosis in the proximal subclavian. We can now get blood flow getting into the common carotid. So now we can stent, come across the stent, and we're actually going to then return blood flow into the subclavian. So now we can then feed the vertebral and the subclavian arteries. So it can be used to restore flow to the subclavian and vertebral arteries in cases of proximal subclavian stenosis. We can also use that graft as well to supply blood flow to the carotid artery. So say the patient had a blockage in that proximal carotid artery. We can then tap into the subclavian and stent the blood past that stenosis into the carotid artery. So then with a carotid graft, as the name implies, we're connecting the two carotid arteries. Carotid. So again, this is used in instances when we have proximal occlusions. So if we have a blockage in the proximal right CCA, so this is CCA, CCA. So if we have again a blockage in our proximal CCA, we can stop blood flow coming up the CCA. We create a graft or connection between the two, so we're able to shunt blood over now into the right CCA, which can then continue up and vice versa. We have a blockage here on the left side, and the right side is open. We can then, shunt blood over to the left side through that graft. If you kind of picture a person's neck, that's their neck. This is going to be, low down when we get to the imaging, the proximal carotid arteries. That's where you'd see that graft. So proximal CCA. So interposition graft, this is the last one. So this is usually an end-to-end anastomosis of a vein section between the native CCA and the distal ICA. So say end to end anastomosis. A vein section. Connecting native CCA with distal ICA. So this is usually performed when a carotid aneurysm is present. Aneurysm is present. Or CCA disease is so extensive that replacement or excision is not able to be performed. So when CCA disease is very extensive, very extensive. So the sonographic appearance of this type of graph, you might take the appearance of a normal carotid artery bifurcation, or one of a continuous vessel from the base to the mandible. And when you're imaging, you look for shadows or a diameter irregularity. It may indicate the anastomosis points of the graft and native arteries. So again, on the PowerPoint, there's a couple pictures that show all these different graphs. So you can go online, take a look at the PowerPoints to better appreciate, what exactly they look like. And if anyone has any questions about anything, send me an email, message me. I'll try and answer you as quickly as I can. Anyway, have a good day, and talk to you all later. Take care.